I'm Harriette Van Spall, Associate Professor of Medicine from McMaster University in Canada, and I'm absolutely delighted to be here at ACC 2021 with Dr. Steve Nissen, Professor of Medicine and Chairman of the Department of Cardiovascular Medicine at the Cleveland Clinic. Welcome, Dr. Nissen.
Thank you.
We are here to discuss your secondary analyses of the STRENGTH trial, which you presented at the late-breaking clinical trial session. I wonder if you could share some background on the conflicting results of prior trials of omega-3 fatty acids and cardiovascular outcomes to provide some context.
So if you look at all of the large trials, so there have been a number of them in recent years. The three big ones were Origin, Vital, and Ascend, all greater than 10,000 patients. They did not show really any effect of fish oil on cardiovascular outcomes, but they studied relatively low doses. And along comes a shocker, the REDUCE-IT trial. And the REDUCE-IT trial shows a really unprecedented 25% reduction in morbidity and mortality. That's using 4 grams of purified EPA, also known as icosapent ethyl. In parallel, we did a 13,000 patient trial called STRENGTH. And STRENGTH showed essentially a completely neutral result. The hazard ratio was 0.99, tight confidence intervals, no evidence of any benefit. And so the question is, how do you explain these disparate results? One of the possibilities was that because the REDUCE-IT trial used purified EPA and we used a mixture of EPA and DHA, maybe we didn't get enough EPA into patients. The other possibility was that the DHA component that we used in the STRENGTH trial somehow was precisely counterbalancing the benefits of EPA and rendering the result neutral. So we did a simple analysis. We looked at tertiles of achieved EPA in the STRENGTH trial to see if people that got very high levels had a benefit. And those people had an increase of 443% in EPA levels. They were even higher than the median EPA levels in REDUCE-IT. And the result was completely neutral. There was no benefit. We looked at the DHA levels, and the group that was in the highest tertile of DHA level had no evidence of harm. There was no evidence that it was somehow counterbalancing the benefits of EPA. And so we conclude from this that it did not seem to matter in our trials what the levels of EPA or DHA were. There is a third hypothesis, and it's the one that I think is most likely. These two trials use different comparators.
Right.
The REDUCE-IT trial used mineral oil. The STRENGTH trial used corn oil. When we were designing the trial, we were well aware that mineral oil had significant toxicity. There was lots of data out there to suggest that it had adverse effects. And so we spent half a day going through all the possibilities. We thought olive oil would be a positive control, that mineral oil would be a negative control, and the corn oil would be neutral. And so we used corn oil. And it was neutral. There were no changes in any of the biomarkers in the corn oil group. In the mineral oil group in REDUCE-IT, ApoB went up, LDL went up, and CRP went up a whopping 32%. And so we think that REDUCE-IT's very likely a false positive study that was driven by the adverse effects of the placebo and not by the benefits of the omega-3 fatty acid that was given. This controversy is going to continue. It's going to continue until we see this purified EPA product studied against a neutral comparator, such as corn oil, or if we can do some smaller studies and look at mineral oil versus corn oil, we might learn some things that way as well.
Right, so there were no other reasons in terms of baseline characteristics of patients or the EPA levels achieved that could account for the differences?
Well, trials are always have different patient populations, but these were very similar. They had similar entry criteria. You had to have triglyceride in the range of around 200 to 500. They had a few more secondary prevention patients. We were 56%. They were in the high 60s. But, fundamentally, they were quite similar populations. And so it's hard to explain it on that basis. But even if there were baseline differences, we saw nothing. I mean, not even a hint of a benefit. And I think that if raising, omega-3 fatty acid levels really works, we should have seen something, and we just didn't see it. And so we have real doubts about whether this is a therapy that clinicians should routinely use to reduce cardiovascular risk. Now, these drugs can be used to reduce triglycerides when they're above 500, because that's been shown to reduce the risk of pancreatitis, or at least it's been suggested to reduce the risk of pancreatitis. It's actually never been really studied in a good clinical trial, but it probably works. It probably does reduce pancreatitis risk. But that's for very high triglyceride levels. That's not for patients in this 200 to 500 range.
Absolutely. Can you tell us a bit about any adverse effects? There is a hint of association with atrial fibrillation.
It's a lot more than a hint.
Right.
In our trial, there was a highly significant 69% increased risk of atrial fibrillation. In reduced, it was a 50% risk. In another recent trial, ONEMI, it was an 89% increased risk. And one of the reasons why we have concerns here is that you have to always look at therapies on a risk-benefit basis. And if there really isn't a compelling benefit, then what you have left is the risk. And risk of atrial fibrillation is not to be ignored. And so, we do urge a lot of caution in using these drugs, particularly in people with a history of atrial fibrillation. And I'm not that caution has kind of gotten trickled on down to the practicing physician yet.
What might some of the mechanisms be for that associated risk
of atrial fibrillation? I wish we knew the answer to that. I don't. It's to me, it's quite a mystery, and it's a good area for young physician scientists to try to figure it out. But we can't explain it. But when you see it in 3 trials, you have to believe that it is it's a real effect.
Okay, so in summary, this sub-study that was exploratory demonstrated no benefit in the use of omega-3 fatty acids on cardiovascular outcomes across the range of EPA tertiles, no benefit and evidence of risk of increased incidence of atrial fibrillation. Great results with important messages for the cardiovascular clinician. Thank you so much for joining us this morning. Congratulations on the original trial and on this late breaker. I was honored to meet you today.
And I just would like to add that the full manuscript is in JAMA Cardiology if people want to take a look and see. There are a lot of sensitivity analyses. They all showed the same thing.
Fantastic. We'll post it when we market this conversation. Thank you so much, Dr. Nissen.
Okay, you bet. Bye-bye.
Bye now.